The next discussion points are going to be onto the cardiovascular system. And this is one of those areas that you really need to have a very strong grasp of when you do anesthesia. This is one of the areas that can get you into trouble when you're managing your cases, and so you have to really understand your physiology so you can understand what's going on in doing the clinical case. Key points first is we're going to go over the basic cardiovascular anatomy. Okay? Then we're going to talk about what are the roles of the cardiovascular system, what are the different compartments in the body and how the compartments are regulated. And then we're going to go on to the full discussion of the cardiovascular physiology. When you look at the actual where the chest, where the heart is actually inside the chest, most of the heart is located inside your left thorax. Okay? The heart is not in the direct midline. It's off more to the left than it is to the right. Okay? There's some portions of it in the right, but only minimal. The actual heart actually takes up the space of one lobe of the lung, and that's why if you look at the left lung, there's only 2 lobes versus the right has 3 lobes. To actually get into the cavity to actually work on the heart, most of the time we do what's called a mesosternotomy, which means we actually make an incision and go through the sternal bone. This is done with specialized saws. They're called oscillating saws, and you'll see those in action in the operating room. Okay? What's important about understanding this is that the anatomy normally is that the heart is separated from the actual sternum itself, usually by a sac called the mediastinal sac, okay, which is actually like a layer. It separates out the heart and the major arteries from the actual bone itself. So in essence, when you're actually doing the first time you open up the chest, you're cutting through this area, and you can actually lift up the sternum and be away from all the vital structures. The importance of this is that this only occurs after the first time. The second time around, when the structures have been disrupted, you can actually get fusion of these structures to the sternum. So the surgeon can actually, on the second go-around, when they have to do a secondary open heart procedure, and they go through the sternum, they have to be very, very careful, because sometimes they'll actually saw right through the aorta or part of the ventricle with disastrous results. Okay, so you have to understand that physiology and the anatomy does change from prior incisions. The aorta and the major vascular structures are something that I expect you to know, okay, especially the aortic arch, where the blood supply goes to the brain. So we'll go into that in a little bit more detail. Okay. The other thing that's important, too, is that the descending aorta and portions of the ascending aorta, as well as the aortic arch, are located mostly, aortic arch and going down to descending aorta, is mostly located in the left chest. And as a consequence, the way we actually approach those is not through a sternotomy, but actually by a lateral approach. So we actually put the person in a right lateral decubitus position, and lift the arm up high, and then make the incisions through the ribs and get into the chest cavity that way, and approach the descending aorta and portions of the aortic arch for repair that way. As you can see, the anterior-wise, this nice picture shows you how the heart is properly stationed inside the chest. Okay, most of the anterior portion of your heart has nothing to do with the left ventricle. Actually, most of the time, the left ventricle is totally non-visible when you open up via sternotomy. So when you're working at the top of the bed and you're looking over the top and looking at the heart directly, you're not really viewing the left ventricle at all. And that's a significant limitation when you're actually doing open heart procedures. One of the reasons that transesophageal echoes were developed was to see the actual left ventricle posteriorly more effectively. The TEE basically views the heart from a posterior aspect because the esophagus is more posterior. So when your view is, the closest view to it is going to be the left ventricle. The reason that the heart is set up this way is actually functionally, survivably reasonable, okay? Which means that if somebody were to punch you into the chest, what actually causes most people to fall down when they get hit in the solar plexus is that they fibrillate, which means that the heart literally goes into an arrhythmia, you lose all pulses, and you drop. Now, if you would punch the left ventricle, the chances of you getting a significant arrhythmia that you would not recover from would be very high. So you'd go into VTAC or VFib. Versus if you punch the right ventricle, you usually go just into a bradycardia, and that's what causes the person to drop. So it is basically increases your survival by having the right side of the heart a little bit more anterior. The other thing, too, when anybody punches you in the chest or you get any kind of direct trauma like hitting a steering wheel, you are going to get energy transferred to the myocardial muscle. Okay? And by the right ventricle being anterior, it's the most likely heart muscle to be stunned. The left ventricle is essentially spared from that stunning, and that's what makes it survivable. Okay? Versus impacts from posteriorly onto the back of your chest, and it transfers the energy into the left ventricle. That has a much higher mortality rate and morbidity rate because the left ventricle is really what maintains your systemic circulation. Okay? This picture shows you also how anatomically the structures are set up, how the aorta literally spins around the pulmonary artery. If you actually were to look at it from the direction of where the valves are located at, okay, from top to bottom, is PAMT. Pulmonary artery is the most superior, okay, followed by the aortic valve, okay, mitral valve, and tricuspid valve. So the most inferior, which means the most towards your feet or caudal, is the tricuspid valve. Okay? The most superior or more cephalad valve is the pulmonic valve. Okay? If you're looking at it from anterior to posterior, which means in this direction, okay, you're looking at what's called PATME, okay, which is pulmonary artery is the most anterior, followed by the aortic valve, followed by the tricuspid valve, and the most posterior is in the mitral valve. So TEE-wise, the most difficult to visualize is going to be the pulmonic valve. Two reasons why. It's the most superior valve, which means it's up by the trachea, so the air actually disrupts the view. And because it's also more anterior, it's more distant from the TEE. So there's two reasons why it's not visible. The mitral valve, on the other hand, is actually very easy to see because it's the most posterior valve. The aortic valve is actually also very easy to visualize as well. The tricuspid, of course, is also. But it sometimes gets down a little bit low and may actually get close to where the stomach is at. And sometimes you'll get a little bit of air interface, but still the tricuspid valve is very visible most of the time. The mediastinum is actually a very important structure that separates out the chest into different compartments. There's essentially four essential compartments. There's the superior, anterior, middle, and posterior compartment, of which the heart is in the middle compartment. The heart is actually protected by a sac called the pericardial sac. That pericardial sac acts like is a double-line sac. It's not a single-line sac, it's a double-line sac that protects the heart not only from the outside world, but also from the lungs and the sternum. Okay? This double-line sac also secretes fluid inside the space called the pericardial space, which is usually around 15 to 25 cc's, which acts like a lubricant. Okay? That lubricant prevents the heart from basically rubbing up against the sac. So it acts just like an oil inside your car and protects the piston from actually losing frictional force effort when it pumps. Okay? What's interesting about the heart is that the heart will be able to shift up and down depending on your breathing. Okay? So if your person is breathing shallow or there's a lot of intra-abdominal pressure, it will actually shift the heart up and more into the left side of the heart. Okay? The heart can also shift from left to right in the mediastinal structure-wise if you get a pneumothorax, and we'll get back into that when we talk about cardiac tamponade and how that affects the physiology of it. Okay? But normally the pericardial sac is a very tough outer layer that protects the heart from things like stab injuries. It does considerably protect it in that respect, but it does not protect it against higher velocity weapons. Okay? When you're looking at it, this normal space in here, which is number 2, that's the anterior mediastinal area. That's the space, usually that's where the saw goes through. There's nothing really important in that area most of the time. If you're looking at a child, the thymus gland can be involved in that area. By the time you become an adult, the thymus gland is pretty much gone, and all that's left is sort of a residual tissue that's not significant. The anatomy of the cardiovascular system is that we are in a closed system. We didn't know this till the 1800s by Sir William Harvey. Okay? Harvey basically described that the heart is a continuous system that pumps into a constant transportation system, which we call the arteries, which then goes into arterioles, which then goes into capillaries, okay? And then the capillaries then return the blood, which is deoxygenated into the venules, veins, and eventually returned back to the right side of the heart, which then pumps it into the lungs. So you have to know that the system is a closed system. The importance of that is that you begin to understand that our circulation is our main transport hub in our body that basically delivers products to the cells and removes waste products from the cells as well. So it's a very essential system. Just like our system is with our roads, if we had a breakdown in our road system right now, you would, let's say you didn't have any fuel for 3 days, all the food in this whole city would be gone. In every major city in the United States would have no more food after 3 days. Just think of that. Okay, if you have not been here in emergencies before, like in hurricanes, you should realize that literally in 3 days, all the food in this area will disappear. So you should have at least weeks and a half or 2 weeks of food available in your pantry at all times. Same thing happens in your body. This happens in minutes, in other words, in the body. If you don't have enough circulation going through, the cells begin to starve. If it's oxygen that you're looking at, then you're looking at 5 minutes survival, up to 15 minutes or 20 minutes in different organ systems, but the brain basically lacks survival after about 5 minutes. Okay. One of the things that I want you to understand is the separation that occurs when you become an adult. In fetal circulation, we'll talk about that some more later on in a different sort of venue. But as an adult, the circulation separates into the right and left side of the right side basically pumps 100% of its cardiac output into the lung. And that's a board test question that they've asked in the past. That's the only organ that actually receives essentially almost 100% of the cardiac output. The left ventricle does not pump into any organ 100% of its cardiac output. It's distributed evenly to different organs, preferentially the brain, which receives around 30% of the cardiac output. But the rest of the organs receive less than that. Okay? But the right ventricle is basically pumping deoxygenated blood to the lung where the oxygen exchange takes place and the CO2 removal takes place. And then it recirculates oxygenated blood via the pulmonary arteries back, the pulmonary veins back to the left atrium, which then pumps it into the left ventricle, pumping it out to the systemic circulation. The venous system is one of those things that you need to understand for several reasons, because you're going to be putting in central lines and you're going to be putting all sorts of IV accesses. So you should understand to a certain degree what the venous system is set up. What I want you to sort of specifically work on is not to memorize all these things. It's just basically to understand that it's the capacitance vessels in your blood stream. Okay? Most of your blood volume is not in the arteries, it's actually in the veins, which is very hard for most students to understand. Okay? About 80% of your blood capacity is actually in your veins, not in your arteries. Okay? So why don't you die if you get cut in the veins? And the answer is because there's different in velocity. Okay? You can lose considerable amount of blood if you hit a major vein. Okay? It's like the ones that will kill you very, very quickly would be an inferior vena cava injury, or the worst one to get hit by far is the portal vein. Okay? The portal vein is about the most scariest thing that you'll ever see injured in the operating room. Okay? All that will happen is, because it's such a low-pressure system, is that abdomen will just fill up with blood, and it looks like it's continuously just pouring in. And you don't see any pulsatile flow, and that's what makes it different. Veins don't have pulsations that much, so you can't really feel where the blood is coming from. So you just are sort of guessing where the blood is coming from. Usually what happens at that point is the surgeon will suck out all the blood, you won't have any blood volume left in the heart, and then the bleeding will stop. So bleeding always does stop eventually. Okay? The bad thing is usually at that point is you're empty. So the venous system is one of those things that you have to understand the anatomy. And some of the basics that you specifically want to work on is the internal jugular vein, the subclavian vein, and the external jugular vein, because those are things that you're going to be putting in IVs when you're working the heart section. The other thing that you want to look at is make sure that you sort of know the anatomy of the hand and the arms to make sure that you can put a good IV access. The other one to consider is the anatomy of the venous system inside the inguinal area, okay, which is the word called navel. It's a mnemonic for it, okay. Navel going from nerve, artery, vein, empty, lymphatic, okay. And the L's always in the middle, okay. So no matter which side you're looking at, it goes the other way, navel, okay. So that's a good way of remembering it. So if you feel pulsation, that means the vein is medial to it, okay, not lateral to it. If you go lateral to it, you're going to get a nerve and may cause injury to them. Instead, you want to go medial to it. What we try to do for you is when you get to clinical, we'll show you the anatomical structures. You have ultrasonography, so you get adept at putting in femoral lines as well as putting in a lot of femoral blocks if you stay here. Yeah. Navel means the inguinal area, okay? The way the distribution is of the blood vessels is nerve, which is the lateral femoral cutaneous nerve, with the femoral nerve connected in the same area, and the obturator nerve. Then you have the next one is the artery, which is femoral artery, followed by the femoral vein, empty, and then lymphatics on the most medial aspect. And L's always in the middle. That's how you know, because if I flip the question on you and I say on the right side, I mean the left side, then navel starts N-A-V-E-L. Okay? The other thing that you may also want to understand is that one of the things that is recommended now by ACLS is that if you're getting into trouble getting IV access, one of the things that you can get into very quickly is intraosseous IV access, which means you can actually put in a catheter needle directly into the bone marrow and as a consequence get medications in very safely. And understanding that structure is via the venous system as well. Venous return via the heart occurs via 3 ways only. There's only 3 ways that the heart will actually have blood supply that's returning via it. One is the superior vena cava. The superior vena cava carries deoxygenated blood that's returning via the brain and the upper extremities. It is one of the lowest deoxygenated components of blood that's returning from systemic circulation. Be very careful about what I just said. Okay, it's the lowest portion coming back from systemic circulation. That's not coronary circulation, but that's your systemic circulation. Okay? The inferior vena cava is the other portion that's returning, that's also deoxygenated blood, but it comes from the lower extremities, including the liver and the portal circulation. It actually has a higher saturation count than in your superior vena cava. So you actually put in an SVO2 catheter and you put it in the IVC, the actual SVO2 would be higher than it would be in the superior vena cava. Once you put it into the right atrium, though, the numbers fall. And they fall significantly to below your superior vena cava and your IVC. And you have to go like, well, why is that? Okay? Because the biggest oxygen extractor by far is your heart, okay, which extracts anywhere between 60 to 70% of the oxygen that it receives. So that comes through what's called the coronary sinus, which is located inside the right atrium is when it returns back. Okay, so when it mixes with the blood, it drops the saturation below all the combined superior and inferior vena cava blood. The other ones that are also returning blood back are the Sebacean veins, which are found inside the heart, and the bronchial veins, which are pretty insignificant in their percentage that's coming back, so less than 1 to 2%. So most of the blood returning back to your heart are the superior and inferior vena cava, and about 5% is due to this coronary sinus. So it's not the most. Okay. If you have to range it between which one has the lowest oxygen concentration, the lowest oxygen concentration is coronary sinus, followed by the superior vena cava, followed by the IVC. Okay? The IVC has the highest oxygen saturation of all the deoxygenated returning blood. Okay? The reason this is important for you to understand is that the all the IVs that you put in somebody's arms, okay, is coming from the arm veins going back into subclavian veins, which then come back into the superior vena cava. Now, I'll give you a clinical example of something like this. We had a patient who had what's called the Pancoast tumor, which is a tumor that's and usually it's located in the right upper lobe of the lung, okay, that was attached directly to the superior vena cava. Okay, the surgeon was working on it. What he was trying to do was dissect the tumor away, and during the dissection, all of a sudden we hear whoosh, big amount of blood starts pouring out of the chest, and it's non-pulsatile. Okay, so we immediately say, okay, well, let's open up our fluids wide open. You know, so we open up our fluids wide open. Guess what's coming out of the chest now? It's basically IV fluids. Now, are we getting anything back to the heart? The answer is no. In that situation, what we had to do was we had to tell the surgeon, stop, compress. We had to go to the legs real quick, throw in a saphenous vein, or a femoral vein. We actually put a saphenous vein, cut down on that one, and then gave fluids that way. Okay. Now, so the importance of that is we should have thought ahead of time. Okay, and I learned my lesson that day. If I'm working any tumor, I'm going to have IV access below as well as above. Just because if we do get into that, then we got something returning back. Because all he has to do is, the surgeon had to do is cross clamp superior vena cava, and that would stop the bleeding pretty consistently. And then we'd be able to resuscitate. If you try to resuscitate with your IV fluids, then it has to go through an accessory system, which is very poor, and it doesn't do very well. And what you end up doing is get a lot of facial edema that develops because of that. So make sure that you have an IV below that if you have this kind of situation. All right. Now, the other returning blood is the inferior vena cava. The inferior vena cava is returning blood from your lower extremities. It also eventually has the portal circulation that eventually binds to it, which is the vein that goes through the liver and basically provides the liver with two blood supplies. There's the hepatic artery and the portal vein. Both provide the oxygenation to the liver, and they'll talk to you about that a little later on when we talk about the livers, I think in another course. The inferior vena cava is important when we talk about pregnancy as well. It's one of the things that will get more compressed by the uterus, and it will cause the lady to drop her blood pressure when the uterus compresses on it. So one of the things that we tell you to do, the inferior vena cava tends to be more located on the right. So we actually will tell you the patient should be put in a left lateral position, usually a 10-degree tilt, which then lets the uterus fall away from it, and you don't get compressible syndromes as well. Okay? The coronary sinus is located inside the right atrium. Okay? It actually is this blood vessel here that's returning all the deoxygenated blood from the coronary circulation. The reason the coronary sinus location is important for you to understand is that very soon you're going to be doing open heart procedures. Okay? And when you work in the open heart, you'll be told that you're going to be doing what's called retrograde cardioplegia. Okay? There's two forms of way we actually stop the heart. There's antegrade or retrograde. Okay? Antegrade normally means that you put the catheter inside the aorta itself, and then you cross clamp it, and then you infuse cold, high potassium solution into the coronary arteries. And what that does is it basically makes the heart cold, one, and it also makes the potassium rise very fast in the coronaries, and it stops the heart. So the person goes asystolic. Okay? And then what that does is it protects the heart cells from continuing to work and cause damage from the lack of oxygen that the person is going to sustain during the cardiopulmonary bypass. The problem with that is that if you have significant coronary artery disease, let's say you have 70 to 80% or higher, perfusion becomes very limited as you're going antegrade. Okay? So because of that, we do it sometimes what's called retrograde. Okay? Retrograde means that we actually put the catheter in the coronary sinus. Okay? And the good thing about atherosclerotic coronary artery disease is the veins inside the heart do not get affected by it. So they're still considered high caliber, big veins. Okay? So when you infuse it, now the fluid goes evenly around the heart and gets the heart stopped more evenly, and you get a little bit more cardioprotection. So we're using a lot more retrograde cardioplegia nowadays than we did, let's say, 15 years ago. and it seems to work pretty well. The basing veins are actually inside the myocardial tissue. It directly bypasses like capillary network, and it causes like a shunt effect that accounts for maybe a 1% shunt that occurs inside the pulmonary system. And then you have the bronchial veins, which are also a form of shunt that provides the bronchial arteries, the bronchioles themselves with their venous return, and basically this returns back to the pulmonary circulation. When you look at the chest anteriorly, at the heart, by the anterior heart, you're looking at mostly the right atrium, okay, and the right ventricle. In this location you see here, that's your right atrium, followed by the groove, which comprises most of the left of the right ventricle. And in this groove itself, right here, is the RCA, which is what we call the right coronary artery. Okay? The right coronary artery connects directly to the aorta. And that's really important if you don't know that. Okay? It directly connects to the aorta. Okay, so it's a blood vessel that directly comes out of the aorta. It's the first of the two branches that come out of the aorta. Okay, so if somebody asks you that, what are the two arteries that come out of the aorta? Initially, the answers are left main and the right coronary artery. Okay, those are the first major, not major, but the important arteries, which are the coronary arteries, left main and the RCA. Okay, now the right atrium is the basic compartment that holds the blood prior to the ventricle going through what's called the diastolic phase. The right atrium contracts during diastole at the end of it to help fill the right ventricle fully. Okay? The RV then pumps during systole and pushes blood through the pulmonary artery, which is basically deoxygenated blood. So it's one of those few examples where you're talking about an artery, but it's deoxygenated. So the pulmonary circulation, when you're talking about arteries, that is deoxygenated blood. When you have pulmonary veins, on the other hand, that is oxygenated blood normally returning back from the lungs towards the left atrium. Okay? If you look at the heart posteriorly, you can see why we talked about this before, about TEEs. The left atrium is mostly exposed with the left ventricle, okay, being posteriorly. Okay. The important structures here are that these coronary arteries also originate for the left ventricle via what's called the left main, and the left main splits into two portions. One is called the LAD, which is left anterior descending, which separates the right and left ventricle via the septal wall, okay? And then you have the circumflex artery, which then rotates behind and provides the left ventricle with most of its blood supply. The coronary sinus is also present back here posteriorly, okay? So you can see here, and that's where it enters, and it returns blood back into the right atrium. Okay, when you look at the heart itself, opening up the structure itself, you're looking at the right atrium here, okay? The right atrium has three main structures coming back into it, which is superior vena cava, inferior vena cava, and the coronary sinus, which is drawn here in blue. Okay? The two yellow dots are important because that's where the locations are of the SA node, which are the conductance vessels, by the conductance cells, which initiates heart rate, and followed by the AV node, which is usually there's street tracks that get there. The AV node then holds the electrical charge for a few milliseconds and then distributes it to the His-Purkinje system into the ventricles. What separates out the right atrium from the right ventricle is a tricuspid valve. The reason it's called the tricuspid valve is because it's got three valves on it. The tricuspid valve is a atrioventricular valve that basically has three papillary muscles, one papillary muscle for each leaflet. And attached to the leaflet is these tendinous structures, which are like parachute cords that help hold the valve in place. The tricuspid valve has three valves, so make sure you remember that. Okay? Not shown here very well is the pulmonary artery. Maybe it's on this one. This one's better here. The pulmonary artery leaves the heart via what's called an outflow tract from the right ventricle. The pulmonary artery is also a tricuspid valve but it does not have any kind of papillary wall attachments. It's a free-floating tricuspid valve. Okay? When you go to the left atrium has 4 pulmonary veins returning back to it. The left atrium is importantly separating out the left atrium from the left ventricle. The actual separation of the structures between these two major structures is the actual mitral valve. The reason it's called the mitral valve is after the name of looking at a priest's hat, which is called a mitre, okay, which is a bicuspid valve. And so the mitral valve is a normally bicuspid valve. Now, what's interesting about the mitral valve is that the valve leaflets are differences in size. One leaflet is actually very large in comparison to the other one. Okay? And it is attached to the papillary muscles via an anterior and posterior papillary muscles, which are important when we'll talk about later on about ischemia and how that affects cardiac performance. The attachment point between the papillary muscles and the actual valve itself is, again, similar to the right tricuspid valve, which is a chorda tendineae, which are these ligamentous structures. These have become important in things like endocarditis. These can also be torn due to trauma and deceleration injuries, as well as due to myocardial infarctions. You will have actually the papillary muscle sometimes break off from the ventricle. The right ventricle is very different than the left ventricle. The right ventricle is pyramidal in shape in comparison to the actual left ventricle, which is more cylindrical in shape. Okay? When you actually show it to you in TEE pictures, you can see how the right ventricle is basically thin-walled versus the normal adult left ventricle is very thick and it basically looks like a circle. The actual outflow tract is where eventually you reach into the aortic root, and you have also a tricuspid valve in the aortic valve area. So there's usually 3 cusps. Some people are born congenitally with a bicuspid valve, which means they only have 2 cusps in that situation. When you're looking at radiographically, what you're looking at the chest, you can actually see the structures that are normally visible. Okay, the lungs should be black. Black means there's air. Okay, white means there's fluid. Okay, so anything that has a lot of white means that it has a lot of fluid. In this case, of course, the heart has a lot of blood in it, so it's going to be white in structure. This shows you a normal anatomical disposition, which shows you the heart being nice and small, with the nice clear lung fields. Again, these are things that you need to understand, as you need to look at, be able to identify the trachea, okay, where it splits in the carina. You see the aortic root here, the aortic knob is right here, and the heart's down here. Just some of the basics that you want to have in mind. So when you look at a chest x-ray, you have some relative idea of what you're looking at. Okay, and you're looking at the lateral image of the heart. Okay, the things that you got to pay attention to, because this is where the heart's at here. Okay, and it's useful in the sense as you can see that the heart's in the middle. It's not anteriorly touching the chest wall. The reason I show you this picture is before you do open heart surgery, and the person's had prior surgeries, you want to look at the lateral x-ray like this, because if the heart is right up against the sternum, touching it like this, then that person is at very high risk for having the sternal saw cut the ventricle in half. So it does make you change to your anesthetic plan. You put in bigger IVs, bigger cortices because of it, so you anticipate that you're going to have more complications and more risk. Okay, it's a nice picture of that showing you the different structures. The pulmonary vasculature is posteriorly, it's stable, and it means that the pulmonary veins don't move. Okay, in your chest, it's pretty much a stationary object. The aortic valve on the other, the aorta itself, on the other hand, is free floating. And the importance of that is that one of these structures will stay in place when you decelerate, and the other one will not. Okay, which means that if you have any kind of attachment point, that means that that other structure will tear. And we do see that with aortic dissections and aortic ruptures, with the attachment point between the left pulmonary artery and the aorta. The coronary arteries, the way you have to know this is that you have to know that there's only 2 major coronary arteries coming out of the aorta itself. One is the RCA, which is the right coronary artery, and the other one's the left main coronary artery. The left main then splits up into the LAD right here and the circumflex. The circumflex provides blood flow via what's called OM1 and OM2, which is obtuse marginal 1 and obtuse marginal 2. LAD, the way you remember it, is it's got a D in the LAD. So the first one's D1 and D2. The way you remember circumflex is, remember that circumflex could be also circumnavigating, which means you're going around the world, okay, and the world is a circle. Okay, so that's why I remember OM1, which O is for the circle. Okay? That's how you know which one's attached. The reason we teach you this now is when you get to clinical, you're going to be given cath reports, and you'll be expected to read them. Okay, so if I tell you that you have an 80% LAD, that means the lesion is in the left anterior descending artery, and I'll tell you which portion it's in. If the person tells you that they have a 90% occlusion in the left main, that's very serious, and it's also what we call the widowmaker, okay, because that is the one that if you lose that one, you lose all the left ventricle perfusion, and the person usually dies right in front of your face. So be very careful of left main disease processes. The coronary arteries are supply different portions of the heart. The RCA basically provides most of the blood supply to the right atrium as well as the right ventricle. It also is very significant in its blood supply, and that's why it's called the right coronary dominant to the SA node. Okay, so when people say dominance, what they're talking about, what is supplying the actual SA node. So if you get ischemia of that, you're going to get more bradycardias. And that's why when you see right-sided MIs, people develop bradyarrhythmias, because most people, 80% of the population, is dominant of their RCA. So if you have ischemia to that side, the SA node doesn't fire properly, and you tend to go into bradyarrhythmias. Okay? The left coronary circulation, on the other hand, the left main provides both the left anterior descending and the circumflex, which basically provides all the blood supply to the left ventricle. The bad thing about ischemia to the left ventricle is that it tends to go into tachyarrhythmias and VTAC and VFib, which are a lot more higher lethality rate. Okay? That's why you've got to be careful with it. Okay? The other thing, too, about coronary arteries is that, and we'll talk about this later when we talk about ischemic heart disease and stuff like that, but the coronary artery circulation for the left ventricle only perfuses during diastole, versus the right ventricle perfuses through the whole cardiac cycle. The thoracic blood vessels are also important structures, as these you can bleed significantly intraoperatively. Okay? Things that are coming back to the heart, of course, the superior vena cava and the inferior vena cava, which we already talked about. The inferior vena cava here is showing you how the hepatic veins are coming back, as well as the portal circulation goes through the liver, okay, eventually reaching into the inferior vena cava. So remember, the portal circulation comes into the liver, then breaks up into the sinusoids, and eventually comes back via the hepatic veins into the inferior vena cava. Okay, the inferior vena cava comes directly, bypasses the liver because it's coming through the lower extremities. There's no reason for it to bring the stuff through the liver. The portal circulation is stuff that's coming from your digestive tract, so it's basically giving digestive products to the liver to work on right away. Okay, so that's why that portal circulation goes directly into the liver. This will become later on in trauma and stuff like that we'll discuss. When you look at the aorta, it's mostly, and you're looking at the descending portion of it, it's going along the left side of your chest. Okay, that's why the best approach is through a left thoracotomy. As it splits in the back, it sends perforating arteries that are going to the spinal cord as well as to the intercostal arteries. So these are important structures at every level. You can see there's literally two arteries that are branching posteriorly. See, it's branching to each side. For every segment of rib, you have one major intercostal artery that's originating from the posterior aspect of the descending aorta. Systemic circulation-wise, things that I expect you to understand is looking at the ascending aorta. You have to know the first branches, which are the coronary arteries, okay, the left main and the RCA. And then it goes into what we call the aortic arch. The aortic arch is an important structure here, splitting up into the innominate artery, which then splits into the common carotid artery and the subclavian artery. Okay, this is the right common carotid artery, which then splits into the right internal carotid artery and right external carotid artery. The other branch that comes off the aortic arch is the left common carotid artery. Okay. followed by the left subclavian artery, which then eventually reaches your left arm. Okay, you have to know these anatomical structures. You also have to know that the nerve overlying this area, you have what's called the vagus nerve, okay, that runs over here. And there you also have underneath, that goes underneath this aorta, is the recurrent laryngeal nerve. Specifically, the left recurrent laryngeal nerve goes through underneath the aortic arch here. Okay, the right vagus nerve on this side will not go underneath the arch itself. The reason that's important is because the right recurrent laryngeal nerve is what actually supplies to your vocal cords. Okay, so if you get an aneurysm or you get direct compression of that, you may actually lose vocal cord function to the left vocal cord. Now, let's go on to the next discussion. Hemostatic role of the cardiovascular system. Hemostasis is basically a process of maintaining constancy of the internal environment. The blood is actually very important for regulating temperature. It's critical for oxygen delivery. Okay? It's critical for maintaining adequate pH, ionic composition, and osmolarity around the cells. Basically, the cardiovascular system allows for transport of oxygen to tissue, transport of essential nutrients to the cells. So it's basically like your major highway system. And just imagine as an analogy that it's if without trucking, without your major highway system, you would not get food down here, and you wouldn't get all the essential components that you need to survive. It's also extremely important for removal of metabolic waste products. Okay, because cells always are continuously producing this stuff, and the byproducts have to be removed. Temperature regulation is also critical, and that's one of the reasons that you can actually figure out somebody's getting perfused adequately. It's just holding their hand. If the person feels warm, most of the time that indicates to you that person is not in shock. There's different forms of shock. Sometimes you do get warm shock, but most people that have warm hands tend to not be in shock. On the other hand, the person's cold and clammy. That could indicate to you that the perfusion is poor, and you're not actually generating enough temperature delivery there because you're not getting enough blood there. Okay? You have to really maintain perfusion pressure, okay, which is very different than pressure. Okay? Perfusion is the key to keep yourself out of trouble. Pressure is something that we monitor, which is inside the artery, but it doesn't really not tell you what's going on at the capillary level at times. So there's a huge difference between these two concepts. And the other thing is, of course, cardiovascular maintains good, tight osmolarity control. Total body weight you account for is that we're basically big bags of water. We're about 60% liquid in our total body weight. Okay, so we're essentially a big bag of water, in which most of this compartment is not inside the vascular tree. Okay, actually only a very small percentage is actually things that we can actually get access to. Most of this fluid is actually inside your cells. And that's good because the cells are very happy maintaining their happy little state, and they do not want to be messed with. Okay? So your body does everything it can to try to keep the body water content at a constant level. Okay? Your total solid body weight is only 40%, which accounts for bones, things like that, things that really cannot be redistributed very easily. If you look at the compartments, you can see it as an upside-down pyramid. It's a pyramid that looks like this. The first compartment, which is the smallest compartment, is only 7%, is your actual intravascular compartment. And that's what we work with every day. When we're putting IVs, we're working only on the 7% compartment. So we're really not working on the major group. Okay? When you almost double this, in other words, you get double the compartment size, okay, you're going out of 16%. It's a little bit more than doubling. Okay? But that is the interstitial space. Okay? So the interstitial space actually separates out the vascular structure before it actually has access to the intracellular compartment. Okay, the intravascular and the interstitial compartment are considered the extracellular compartment. Okay, so the most important compartment, which of course we don't have the least amount of direct monitoring method, is the intracellular compartment. Okay, which is basically 35%. If you think about it as a pyramid like this, it makes it easier for you to memorize. That's why I'm showing it to this way. Okay? Now, the reason I also show you this method is that every one of you has been told at one time that if you see somebody bleeding, okay, they'll tell you how much fluid should you give somebody who's bleeding. If you have 250 cc's of blood loss, how much fluid do they tell you to give? 750, right? Now the question is, why? Very good. Okay, she's got it on the nose. Because when you give the 750 cc's, it distributes into the extracellular compartment. And there's 3 chambers in there. Okay, each one's only going to have 1/3 of it. So there's going to be 250 cc's in 30 minutes left in the intravascular compartment. And the other 500 cc's are going to be in your interstitial space. Okay? And that's where they came up with this, okay, from these studies. Now, the danger of just giving people just lots of fluids, and we were trained a long time ago to do that, that's really, I think, a mistake. Okay? And they're starting to find out to be true. They're starting to now give more whole blood to people in trauma patients, and they're seeing that their survival goes up. Because what ends up happening is if you keep giving all this fluid into the interstitial space, it keeps filling up. It gets wider and wider and wider. And what ends up happening is the distance between your blood vessel itself to the intracellular compartment gets wider. Okay? And that can limit your oxygen delivery as well as your nutrient delivery, I think. Nobody's been able to prove that, so I'm just telling you that's a theoretical consideration. But all I can tell you is from when I worked as an ICU doctor for several years, anybody who came out with a lot of edema, they were a lot more difficult to deal with than somebody who was given more blood and resuscitated more appropriately. So try not to over-resuscitate with just clear liquids. If somebody's hemorrhaging, give them blood. That's what I'm trying to imply to you. You'll see people argue with, oh, well, albumin is better than crystalloid. It's all a bunch of BS. Okay, it doesn't matter which one it is, because ultimately what stays intravascular is blood vessels. Is your hemoglobin, is your red blood cells. These are big cells that they stay inside. So all the other stuff, even if it's albumin, does not really stay intravascular. It will escape into the interstitial space. Okay. The 35 compartment is basically the intracellular compartment. But when we draw blood gases, when we draw your blood test, all those tests are only coming out from one compartment. So the inference of your value to what's intracellularly going on can only be what's called inferred. It's not a direct measurement. There's no way that you can actually do a test where you put in a needle into a cell directly to measure the actual intracellular compartment. So always you have to keep that in mind, that what you're really monitoring in the operating room when you draw a test is that you're only monitoring the intravascular compartment. Okay. The extracellular compartment is actually 40% of your liquid or 20% of your total body weight. It's composed of mostly the extracellular compartment of the interstitial, which is 25% liquid, 16% of your total body weight. Cells must draw nutrients to this area, and cells must deposit their waste products here. So this is basically a compartment separating your cells from the actual blood vessel. Now, is this found everywhere in your body? And the answer is no. Okay? The only place where it's not found, though, is in your brain. That's the only place where you don't have this interstitial interspace. And the brain is one of those unique structures, although it separates out the blood vessel directly from the actual cell, is the actual blood-brain barrier, which is another cell, the astrocytes. But for the rest of your body, this is considered consistent. That's why you don't see, when you give a bunch of fluids to somebody, do you normally get somebody to develop brain edema? The answer is no. That's why. Okay? If you had this kind of system in the brain, you get a lot of brain edema and the person would herniate. Now, can that still happen? The answer is yes, it can. If you have somebody who has a disrupted blood-brain barrier, let's say they got shaken, okay, or they got into a decelerating car accident where their head got shaken all over the place, and you start pumping a bunch of fluid into them, that person may herniate on you in the operating room. So you've got to consider that as well. Okay? The intravascular compartment accounts for 70% of your total body weight. This is what the heart is pumping, the small part of your total body water, which is why it's evident here. It must maintain a constant fresh nutrients and remove your waste products. And the way it transports stuff is via convection. That's an important word, convection. Okay? It doesn't do it by conductance, it does it by convection. Okay, so make sure you got that wording down. They've asked that before, so I just want to make sure that you get the wording down. Again, most of the things in medicine are, some people decide to use words that nobody uses, so this is one of those. Okay? I think I'll stop here, give you guys a 10-minute break, and we'll start back up.